Hi, this is Brandon with Chiro Up, and I want to talk a little bit more about slap lesions today. And the reason is we see a lot of slap lesions, and it's independent of patient age or activity level. And the reason is slap lesions are very common. What we see is we see 28% of people that are asymptomatic have a slap lesion. So we see these in the same frequency that we see degeneration in the lower back. Now, here's the problem, is that a lot of these people don't just have a slap lesion, they have other issues going on, one of those being a rotator cuff issue. And when we start to see rotator cuff issues, and we start to see slap lesions, especially in a younger population, we have difficulties getting these people back to their sport. In fact, a recent study just came out, 7 to 57% of them go back to past performance. That's not a whole lot. So what we're seeing is this trend of going from surgical repair to a conservative management or a solution. Now, conservative management solution should of course involve a team of people looking at the condition, but most importantly, having the right diagnosis and knowing who's surgical and who's not surgical. So first, let's review the test for a slap lesion. The first one is the active compression test. What you're going to have the patient do is elevate their affected arm to 90 degrees and with the thumb down. When you push down and they resist, you're going to have pain or no pain. When you have pain that's deep-seated in the joint, that's reproduction of more of a slap lesion type pain, since you're pulling more at the biceps tendon. If they're getting pain that's superficial on top, it's more indicative of an AC type lesion. Now the differentiating test is after you perform this test and they have that deep-seated pain or reproduction of their chief complaint, then flip the wrist over, keeping the elbow extended, and then push up again. If the pain goes away, then it's indicative of a slap lesion. Now your second test is a biceps load test. You're going to bring the arm up, and I tell the patients I'm just going to arm wrestle with them. They're in 90 degrees of forward flexion, bring them into full external rotation into abduction, and then you're going to pull at their arm as they resist you like they're going to arm wrestle you and relax. If they get reproduction of pain, it's positive for a slap lesion. And the last one is a crank test. This is where you're actually going to have to feel for crepitus or popping, clicking, grinding within the joint. So you're going to actively compress into the joint, and now you're going to go through internal and external rotation. One, pain is a positive test, but also you're actually feeling for any kind of disruption within that labrum. So what do we do about it? Well, the biggest thing as conservative management that we can do for these patients is to look for loss of range of motion. Because when these people have loss of range of motion and they try to go back to their sport, what we find is they have very characteristic problems. So especially for a slap lesion, we're going to see more of a forward lean when they're pitching or throwing a ball. We're going to see loss of external rotation. We're going to see loss of horizontal adduction, meaning they just don't want to go through that full range of motion. So the way I test that in my office is just having them on both the affected and unaffected arm is going through internal and external rotation passively. So how far can they go into internal rotation? How far can they go into external rotation? If there's a loss of range of motion, that's when we're going to go into more of our sleeper stretch or any stretch that you use in your office, both actively in your treatment room or at home would be great. I'll post a link to the stretch that we use in our office. Now the last thing is, what are we going to do for these patients at home? Well, I need to teach this patient, whether it's a young patient or whether it's someone who's trying to go back into their sport, how to avoid this pain, how to improve scapular stability, and keep on irritating that labrum. So what we use is a scapular repositioning test, but we turn it into an exercise. So what I have my patients do is learn how to use the scapular stabilizers. So I have my fingers and I pinch together their medial border of their scapula in towards their spine. Not only do I bring it towards the spine, but I bring it down in more of a posterior tilt, because often people will substitute those upward rotators and have that hunched presentation that we see so often with our rotator cuff patients. So teaching our patients how to keep their shoulder down and posterior tilted as they go through a range of motion. So if it's an older individual, when they get their cup out of the coffee cup out of the cupboard, instead of just reaching up like this, is teaching them how to rotate their shoulder down and then separate that glenohumeral range of motion from their scapular range of motion. And the same thing goes with my, my patients, is that if I'm going to have this patient do eccentric strengthening of the supraspinatus, I'm going to have them with the weight, arm fully extended, arms down, and slowly going down, as you can see in this video here. Now with this patient, I can just send her these videos, or I can actually teach her how to posterior tilt her scapula as she's going through this range of motion. If I can teach her how to have better quality of exercise while she's doing her weightlifting with her team, while she's doing my rehabilitation exercises, I'm going to have better results, and my conservative management is going to get them back to their performance quicker, faster than a surgical approach, especially if it's a type 1 or type 2 labral lesion. Thanks for checking out the blog. I hope you got a little bit of information on how to diagnose a SLAP lesion and a couple strategies to manage in your office using chiro exercises and management tools. I'll see you next week.